Everybody. This is Dr. Kaushal from the medical team of USV, and I welcome you all the speakers in the expert panel for the CME India initiative brought to you by none another than Dr. N.K. Singh sir and collaboration with Team USV. So our today's topic of discussion will be diabetic ketoacidosis by Dr. Anil Samaria sir, and Beyond the Plaque, that is about lipid dynamics in the eye of the coronary stone by Dr. G.P. Sattu. Without further ado, I would like to invite the person behind CME India Group, that is Dr. N.K. Singh sir, Director Diabetes and Heart and Research Center, Dhanbad, and having numerous publications to his credit and associated with so many organizing committees. So it's great to have you with us today, sir. I welcome you on behalf of Team USV and over to you for the further proceedings.
Good evening. Thank you, doctor. Now I invite all today's all our moderators. Welcome and our two speakers. So today there is a bit change from our pattern that we have two speakers, two very important topics. So I welcome audience of CME India. I think this is a huge audience every time. This is our monthly webinar. So today our speaker, I think, can you show this slide later on? So first I will introduce all the moderators of the today's seminar. So next, technical team. Yeah. Next. Yeah. So today, a very eminent person here, that is Chandrasekhar from the Chennai, Head and Professor of Medicine. He is also Joint Secretary and Treasurer, Chennai chapter of API, National Faculty Council member of the ICP. He is honorary State Secretary of this Indian Association of Clinical Medicine and Indian Society of Hypertension. So many publications. So he is also reviewer of many journals, recipient of Best Doctor Award by the Tamil Nadu government also, and Award for Excellence in Diabetes Care. So welcome, Dr. Chandrasekhar. Next. And here is Dr. R.K. Modi from the Bihar, Purnia. He is an eminent physician and diabetologist from this part of Bihar that is known as Purnia. Chairman-elect of API 25-26. He has been also the past chair in the CCDSI Bihar and Jharkhand 25. He is now governing council member of RSSDI Bihar. Fellow of Indian College of Physicians, Fellow Indian College of Cardiodiabetology. He has a huge interest and huge research on the food care training by a step-and-step project of India. And to his credit, I think many workshops are being done on the diabetic food. So welcome, Dr. R.K. Modi.
Thank
and
you,
our
sir.
next moderator today, so is Dr. Sasank Prabhu Desai. He is consultant physician and cardiodiabetologist at Prabhu Desai Clinic, Goa. And at present, he is the chair of the RSSDI Goa chapter. He is PG Diploma in Cardiology, Federation of Royal College of Physicians, UK. Also done a fellowship in echocardiography, ex-senior resident in nephrology at JIPMER, Pondicherry, ex-assistant professor in medicine at Goa Medical College, and also a secretary association of physicians of India, Goa State Chapter, present. So welcome, Dr. Sasank Prabhu Desai. And now I will request Dr. R.K. Modi to introduce our first speaker and invite him for his presentation. Dr. R.K. Modi. So
Sure,
can you
thank
go
you,
for
sir.
the first, Dr.
Yeah,
This one.
yeah. Our first speaker is Dr. Anil Samaria, intelligent, very smart speaker. He's principal and controller, Jawaharlal Nehru Medical College, Ajmer. He's dean, faculty of medicine, Jaipur. It is head of department of medicine in Jalan Medical College, Ajmer. Senior professor, consultant physician, unit head, and he did MD in medicine, diploma in diabetology, and fellowship in endocrinology, fellowship in Innovative Physicians Forum, and fellowship in Indian College of Hypertension. Also, welcome Dr. Samaria, and I will request you to start the first deliberation.
Dr. Anil, before that, Dr. Vijay Patni has joined. Do you
welcome,
have
Dr.
the
Vijay Patni.
PPT of Dr. Vijay Patni? Technical team, please go ahead. So here is Dr. Vijay Patni. He is HOD. I think he needs no introduction for this audience. So many research, so many membership. So welcome Dr. Vijay Patni and also Dr. Akash Singh. Can you show the PPT of Akash Singh? Yeah, so that is a Hage also a chair at the ICDM, Baroda, and invited faculty at many conferences. So doing a great job in the internal medicine. So welcome Dr. Akash Singh. Now Dr. Anil Samaria, you can take over. Yeah.
Thank you, Dr. NK Singh. Good
Yeah,
evening.
stop this sharing. Stop this sharing. Technical team. Fine.
Good evening, everyone. Thank you very much, CME India, to invite me as a faculty to deliver a lecture on the diabetic ketoacidosis. And I thanks to Dr. G.P. Satul. He's another speaker, Dr. Shashank Chandrasekhar, Dr. R.K. Modi, Dr. Shashank Prabhu Desai, Dr. Akash Singh, moderator, and Vijay Patniji. Welcome here in the platform of CME India. Today's topic is diabetic ketoacidosis. My slide is visible or not?
No, you have to share. Yeah, share it again.
Wait. Now it is visible now?
No, I
Not
think
yet, sir.
no.
You need to share it, sir.
I think he shared a bit few minutes before.
It is showing or not?
No, not showing at all.
Showing it.
So you need to share it, sir. Share button is still green.
Just wait. Here.
Yeah, now it is okay. You have shared it. Yeah. Now you can go in slide mode. Slide show, you can start now. Yeah, fine. So you
Okay, thank
go
you
the first, yeah,
for
first slide, you go
inconvenience.
to first, now, yeah, first slide, you go to first slide.
It is
Yeah,
visible
that's fine.
now?
Now visible,
Yeah,
yeah.
thank you.
Everything is fine. Go.
Thank you. Welcome you all in the chapter of CME India. Today's topic is diabetes ketoacidosis. You know that DK is a complication of diabetes. The diabetes, we know that it is a full of complications, acute, chronic. In the acute complication, the diabetic ketoacidosis are very known and very common in the day-to-day practice. Hyperglycemic hyperosmotic state is another acute complication of diabetes. Hypoglycemia we face in day-to-day practice also. The chronic micro and macrovascular complications and other common complications are diabetic foot ulcer and infections. Now, we are concerned about the diabetic ketoacidosis. As we know that it is a state of metabolic decompensation which occurs as a consequence of severe deficiency or absolute deficiency of insulin. And this leads to a hyperglycemia, ketosis, ketonemia, acidemia, and this leads to a picture of diabetic ketoacidosis. The decay occurs in the setting of more insulin deficiency or when the low circulating levels of insulin lead not only to hyperglycemia and dehydration, but also to production of ketone bodies and production of acidosis. Then leads to acidosis in the body. This is diabetic ketoacidosis. There are lots of problems with this. There are mortality rate of decay in children is very high, 0.15 to 0.31%, and the risk of decay in patient in established type 1 is 1% to 10% per patient per year. Decay is a leading cause of death of patient with diabetes who are younger than 24 years old. About one half of death in this population is very common. Before discovery of insulin, 1922, the mortality rate due to decay was virtually 100%, which reduced to 29% by 1933 and the 15% by 1950. The mortality rate ranging from 2.5 to 9% among patients admitted with decay have been reported in more recent studies. But nowadays, because of lots of insulins are coming and we are aware of the diabetes in the early age, we can manage very well because awareness in the villages also, the mortality is reduced nowadays. Diagnostic criteria of decay is depending on arterial pH. Let's differentiate into mild, moderate, and severe. Plasma glucose must be more than 250 milligram in mild, moderate, and severe conditions. Arterial pH differentiate between mild, moderate, and severe. In mild condition, pH around 7.25 to 7.30. In the moderate condition, the pH around 7 to 7.24. In severe condition, pH is less than 7. Serum bicarbonate in milliequivalent per liter. In the mild condition, they are 15 to 18. In the moderate, 10 to less than 15. In severe condition, the serum bicarbonate level is less than 10. The urine ketone and serum ketone positives in all the conditions. Effective serum osmolarity is variable in this condition. Anion gap is very high in diabetic ketoacidosis, more than 12, and mental stress is patient is alert in the mild condition, alert and drowsy in moderate, and stupor and coma in the severe condition, because coma is a feature of HHS and very rare in the diabetic ketoacidosis. If present, mortality is very high. What are the precipitant factors that leads to decay? The most common cause are infection, especially pneumonia, insulin. Other factors that include are myocardial infarction, cerebral vascular accident, acute pancreatitis, alcohol intoxication, trauma, and drugs. Usually occur in the newly diagnosed or inadequately treated type 1 diabetes also. Rarely can occur in poorly controlled or neglected type 2 diabetic patients. Now, this is a picture of how is diabetic ketosis produced. This is a pathophysiology of DKA. Here is the insulin deficiency. And increased counter-regulatory and leads to glucosuria, increased excretion of water and dehydration, simultaneous loss of sodium, potassium, magnesium, phosphorus. These are the electrolytes commonly lost in the urine. Another pathophysiological factor, these hormones act on the adipose tissue, leads to decreased glucose utilization in adipose tissue, leads to lipolysis, decreased lipogenesis. That's favoring development of free fatty acids. This is a major component to produce ketone bodies. That is ketogenesis leads to ketonemia and ketonuria and leads to acidosis in the body. What about the muscles part? There is a decreased glucose utilization by the muscles, resulting in increased proteolysis and increased availability of the amino acids for the increased gluconeogenesis in the liver. Then again, this leads to hyperglycemia. All picture leads to severe dehydration in the DK patient, leads to decreased GFR, and finally the renal failure. This is the diabetic ketoacidosis pathophysiology. Now, what is the clinical picture? The symptom is very known. Insidious increased thirst and urination is very common. Patient complaining of thirst, urination, nausea, vomiting. Mainly it is caused by beta hydroxybutyrate and generalized weakness, easy fatigability, altered consciousness, and symptoms on are also present associated intercurrent illness like infection, if pneumonia is there, complaining of chest pain, urinary increased frequency, urination, and all these complaints. If cardiac pain is there, the MI is also reading factor. These symptoms can be presented feature in the precipitating events. Now, signs are there are signs of dehydration, especially shrunken eyes, dry tongue, loss of turgidity of skin, acetone breath. Signs of acidosis are also present. Tachypneic patient, shallow rapid breathing, air hunger. This is osmolar respiration, a very characteristic of DK patients. Abdominal tenderness is there because there is a pain abdomen that leads to abdominal tenderness. Disturbance of consciousness in the severely affected patient. Signs of intercurrent illness are also to look for these patients. Now, what is the initial level values in these DK patients? Glucose level is more than 250 milligram per deciliter. Urine ketone body is strongly positive. Bicarbonate less than 15 milliequivalent per liter. pH between 6.8 to 7.3. Sodium low, normal or high depending on the hyperglycemia. Potassium is low, normal or high. Phosphate usually normal or slightly low. Blood urea nitrogen and creatinine usually mildly increase in these patients. Now, what is the general principles of treatment of DK? There is an intravascular volume expansion is required, correction of deficit in fluid, electrolytes, and acid base status should be known. initiation of insulin therapy to correct catabolism and acidosis, treatment of precipitating cause, observation of vital signs, recording of timed urine flow and amount of infusion, monitoring of glucose, pH, and electrolytes, use of timed scale flow sheet, and definitive protocol should be in hospital. Prevent the complication and provide education follow-up of the patient at the time of discharge. What is the goal of treatment of DK? Improvement of the circulatory volume and tissue perfusion, general reduction of serum glucose and plasma osmolarity, correction of electrolyte imbalance, and in DK, steady resolution of ketosis, and identification and prompt treatment of comorbid precipitating causes are very important. How to treat mild or ambulatory ketoacidosis? Patient can ingest or retain oral fluid without any difficulty. Keep a patient on the oral hydration therapy. Ask to the patient to small sips of sodium containing fluid frequently, like lemon water, without sugar. Insulin usually needs around 0.25 to 0.5 unit per kilogram, may repeated every 4 to 6 hourly. Monitoring of the patient in the daycare center, blood glucose every 2 to 4 hourly, should be observed in hospital for at least 6 to 12 hours. If ketones are washed out, no signs or symptom decay can be discharged. Moderate to severe decay patient. The patient cannot retain oral fluid. Patient with altered mentation or these patient needs admission and preferably in a high dependency unit is required. Now, component of the treatment. Very important part is fluid therapy, electrolyte correction, insulin therapy, replacement of sodium bicarbonate if needed, treatment of precipitating factor, frequent requirement of glucose monitoring and lab monitoring are important component of the treatment. Now, IV fluid is the gem of the treatment of decay because administration of fluid only can correct 50% of decay and as well as symptoms and signs, also the decay part. Start with the administration of normal saline as indicated to maintain hemodynamic status, then follow the general guideline. Normal saline for first 4 hours is required. Consider half saline thereafter. The change to 5% half NS when glucose level reaches to 250 milligram per deciliter or below. This is a beautiful table that show how can we approach to the fluid therapy in DK patient. This is a first half to 1 hour required 1 liter, second hour required another 1 liter, third hour required 500 to 1 liter, 4 and 5th year per hour also required 500 to 1 liter of fluid. Total first 5 hours required 3.5 to 5 liter fluid in the initial 6 hours because the deficit is more than 6 liter in the diabetic patients. Now next 6 to 12 hours we give the 250 to 500 ml per hour depending on the hydration status of the patient. This is a beautiful chart by the ADA describe the IV fluid therapy determine the hydration status of the patient previously in the casualty or in the ICU setup. If patient in the hypovolemic shock, administer normal saline 1 liter per hour or plasma expander if a patient is in refractory shock. Mild hypotension is there, evaluate corrected serum sodium. Serum sodium should be corrected for hyperglycemia. Measure sodium drop by 1.6 millimole per liter for every 100 milligram per deciliter rise of blood glucose above 100 milligram per deciliter is a formula. So serum sodium is high or normal, start half saline 4 to 14 ml per kilogram per hour depending on the patient's hydration status. Serum sodium is low, continue with the normal saline, transfer at the rate of 4 to 14 ml per kilogram per hour depending on the hydration status of the patient. If it is patient in cardiogenic shock, only monitor hemodynamic monitoring is required because IV fluid can lead to precipitation of heart failure. Now come to the second part is insulin therapy. Insulin is used to treat the acidosis, not the hyperglycemia. Insulin should never be stopped if ongoing acidosis persists. When the acidosis is corrected, the continuous insulin infusion may be discontinued and subcutaneous insulin initiated. With this regimen, decay usually fully corrected in 36 to 48 hours. This is a flow chart. We generally use a IV route. Give the insulin regular is preferable as compared to short-acting insulin. But nowadays we can use a short-acting insulin also. But regular insulin is preferred. 0.15 units per kilogram as IV bolus in the initial stage. Then go for 0.1 unit per kilogram per hour IV insulin infusion continuous. If blood glucose level does not fall by the at least 10% in first hour or 50 to 70 milligram per deciliter in first hour, you can double the dose or continue monitoring every hourly blood sugar to be checked. If double infusion is required until the glucose fall by 50 to 70 milligram per deciliter. Sometimes we can't access the IV lines, so we can go for the IM for especially the mild cases. Insulin regular 0.4 unit per kilogram, half as a IV bolus if you access the IV line after that. 0.1 unit per kilogram per hour regular insulin subcutaneous or IM in the mild cases. If serum glucose does not fall by the at least 10% in first hour, give hourly IV infusion 10 unit until glucose fall by 50 to 70 milligrams per deciliter. Now, practical points on the insulin therapy. Very important. A low dose insulin regimen has advantage of not inducing the severe hypoglycemia or hypokalemia as may be observed with a high dose insulin regimen. Subcutaneous absorption of insulin is very reduced in DK patient due to dehydration. Hence, using IV or IM route is always preferable. Insulin dose in the we showed in the table previously. Starting dose is 0.1 to 0.2 unit per kilogram per hour. Expected drop in blood glucose 75 to 100 milligram per deciliter per hour. That is 10% per hour is needed. Monitor glucose level every 1 to 2 hourly. When resuming subcutaneous insulin, continue drip for 30 to 60 minutes after initial dose is given. A common mistake is to allow the blood sugar to drop to hypoglycemic level. That can lead to very dangerous. And this mistake usually results in a rebound ketosis and derived by the counter-regulatory hormone. Rebound ketosis requires a longer duration of stay in the hospital and patient may go into the serious condition. When serum glucose reaches 250 milligram per deciliter, change to 5% dextrose with half saline at rates of 150 to 150 ml per hour with adequate insulin IV infusion to keep serum glucose between 150 to 100 milligram per deciliter until metabolic control is achieved. Check electrolytes every 2 hours to 3 hourly or 4 hourly. If potassium, check every 2 hourly. Check BU and creatinine glucose every 2 to 4 hourly until the patient is stable. After resolution of decay, if patient is NPO, nil per oral, continuous IV infusion and supplement with subcutaneous insulin as needed. When the patient can eat, initiate a multi-dose insulin regimen, including basal insulin and adjust as needed. These are the electrolyte deficit in the adults, especially sodium, chloride, potassium, calcium, phosphate, all are deficit. These are the values. Potassium therapy, very important part. Before giving the insulin, we check the potassium level. If potassium level is less than 3.3 millimole per liter, hold the insulin. Give the 40 millimole or milliequivalent potassium per hour till the serum potassium reaches to more than 3.3 millimole per liter. Otherwise, no insulin therapy can harm to the patient because of severe hypoglycemia or cardiac systole or cardiac arrhythmia. Patient potassium level between 3.3 to 5 millimole per liter. Give 20 to 30 millimole potassium in every liter of IV fluid. Target potassium 4 to 5 millimole per liter. If potassium level is more than 5.5 or 5, don't give potassium. Monitor the patient every 2 hourly. If required, transfuse the potassium IV. Bicarbonate therapy is not required in the DK patient. Assess the need for bicarbonate therapy required or not. If pH is more than 6.9, no bicarbonate is required. Therapy with insulin, and hydration can correct acidosis. pH if less than 6.9, go for bicarbonate therapy. Sodium bicarbonate 100 millimole dilute in 400 ml of water. Infuse at 200 ml per hour with 20 millimole KCl because bicarbonate reduce the potassium in the body. So we require a 20 millimole KCl transfer simultaneously. Repeat bicarbonate administration every 2 hourly until the pH is more than 7. Monitor serum potassium level every 2 hours to 4 hourly depending on the patient's condition. If distilled water is not available, saline can be used. One ampoule of 7.5% bicarbonate containing 44 millimole. Now come to the decay complications. Age of the patient and depth of the coma are the best prognostic indicator in these patients. Mortality is less than 10% if timely treated. That is usually due to infection, arterial thrombosis, myocardial infarction, cerebral accident. Unrelenting shock is another cause of death. Individual at extreme of age or those precipitating in the shock, presenting with the shock or coma are more likely to die because of these patients are very dangerous. So be careful in these patients. Cerebral edema, primary cause of death in the children, may be due to rapid fall in blood glucose and early treatment with mannitol and glucocorticoid is not recommended nowadays, but mannitol can be given. If patient is severely comatose, can be given glucocorticoids, but be careful about that. Blood sugar level can up. These are the picture they're showing the how cerebral edema develop in decay. General care of the patient. ECG before the administration of potassium is important to check any arrhythmia is there or not. Review the urine output, vital signs, neurological status, and laboratory data. Frequent assessment of clinical status and repeat physical examination. Protection of airway in the unconscious patient. Nasogastric suction as indicated for the ileus, emesis with the vulnerable airways. Do an X-ray to find out any pneumonia or other causes of pulmonary infection. Other imaging studies if required. Search for treatment of precipitating cause like infection, urinary tract infection, pneumonia, myocardial infarction, cerebral accident. These are also dealt with simultaneously. Hypotension usually respond to adequate fluid replacement therapy. No need of dopamine and NORAD in these patients. When required, go for the NORAD first, then the dopamine. Central venous pressure monitoring in elderly or if cardiac disease is present is required. Frequent ECG monitoring may warn of hyper or hypokalemia, but should not replace the regular plasma potassium measurements. Cerebral edema, deal with the mannitol. Dexona if required, but be cautious about hyperglycemia. Brain imaging to exclude other pathology. Adult respiratory distress syndrome patient is require 100% oxygen therapy or ventilator therapy. So we must avoid a fluid overload in this, especially in cardiac patient, renal failure patient, anemic patient. So be careful about the fluid therapy. Thromboembolic complications are very common in these patients because they are very prone to develop thromboembolic phenomena. Treat if occurs, not prophylactically. Consider mechanical ventilation to accelerate CO2 elimination in severe acidosis or in CO2 narcosis patient. Thank you very much for listening me very carefully, and I'm taking not much of time. Thank you. Thank you.
Excellent one. So I think there are 4 or 5 questions I have received at Anil Samaria. So I think it will be better if you answer now. So then we can start with the second talk. One question is, can decay occur with normal or low blood sugar? So what's the answer? He asking
Decay
that
can,
whether.
diabetic ketoacidosis can occur in alcoholics.
Mhm.
It is not a decay, it is acidosis.
Yeah, that is, I
Right?
think, EDK,
Acidosis.
euglycemic diabetic ketoacidosis, which you are
Especially
getting.
in euglycemic diabetic ketoacidosis occur in the patients on the therapy or SGLT2 inhibitors can lead to euglycemic decay.
A second question is, what is the most common precipitating factor for decay?
Most
what is
common
your
we see
experience?
in the day-to-day practice in type 1 is a missed dose.
Yeah.
But in the elder patient or adult patient, the common factor is infection, especially pneumonia. We must search for that. Or urinary tract infections are very common in nowadays because pneumonia is lesser. But urinary tract infections are very common in nowadays, especially in the rainy season. They precipitate a decay in this season.
Two more, always I think whenever the decay is discussed, people ask why is bicarbonate therapy controversial in decay? So,
Because most of the patient recovered with the fluid therapy, acidosis will be recovered. So the bicarbonate therapy is not required because if you're giving the bicarbonate in early stage, can lead to severe hypoglycemia, can produce arrhythmia or cardiac asystole. So be careful. Bicarbonate is not required. You all have seen the most of the patient are recovered with the fluid therapy and insulin therapy as they recover of all the acidosis. But bicarbonate is only required when pH is less than 6.9.
yeah. So I think a last question which I have got, insulin infusion is essential in decay. Do you go for insulin infusion or subcutaneous infusion sometime? What is the answer?
Insulin
Or,
infusion is must.
yeah. So in most of
Insulin,
cases, I think.
especially with the regular insulin, is a very commonly practiced because it's a very tested insulin and very good results. Short-acting insulin are nowadays in practice, but regular insulin gives no hypoglycemia. We are very well versed with the regular insulin monitoring. So it is better to use the regular insulin continuous infusion, 0.1 unit per kilogram per hourly. It is a dose and monitor every blood sugar level every hourly. The rate of fall is 50 to 70 milligram per deciliter. Double the dose of infusion if required.
So I think one more question has come, last question, that is which one is better, the normal saline or this ringer lactate?
It is better to use normal saline. Ringer
So now
lactate.
we will, yeah. So I think now one by one, Dr. Chandrasekhar, have you got any comment on this presentation and questions?
Yeah, it's a nice presentation by Dr. Anil Samaria. I would like to add certain things, although he has already mentioned about the precipitating factors. So some of the drugs also can cause. Sometimes the patient may not be telling if they are on any antipsychotics, particularly the olanzapine and clozapine kind of drugs can cause, steroids can cause. So this is also a common precipitating factor. Sometimes the patient may not, unless we put a leading questions. The second thing is like with regard to the thing, the insulin, the IV fluids, like which he has already mentioned. But I would like to go with the balanced crystallite solution. Because if when you pour in with a lot of normal saline, there is a possibility of hyperchloromic metabolic acidosis that itself can make the acidosis worsen. So now the recent concept is to give the balanced crystallite solutions, so maybe in the form of ringer lactate, plasmolite, or normosol. So this is the thing. Of course, you can give normal saline, but you need to mix and match with the other balanced crystallite solutions. So that is because you will have to rush the fluid 15 to 20 ml per kilogram body weight in the first hour. So you need to pour in a lot of gush in lot of IV fluids. So that's a thing which I would like to mention. Of course, he has already nicely mentioned about the insulin thing. Like before we embark on the insulin, like we need to check the potassium and we need to keep monitoring the potassium. If it is less than 3.3, we cannot initiate the unless we correct the potassium. Like we cannot do that kind of thing. Of course, he has already mentioned about the acidosis part of it and the bicarbonate controversy part of it. So unless the pH is it's all individualized. There are various guidelines, each one has got a different values for the initiating the patient on bicarbonate therapy. By consensus, we can make the patient prepared and do the do with injection bicarbonate therapy once the pH is less than 7.1. If it is less than 7, it's clearly indicated. And the worsening of the acidosis will take more time, sometimes, particularly in patients with alcoholics, it may take more time. If the patient is having sepsis, it may take more time. That needs to be explained to the patients. So one important thing is when the patient is on IV insulin and the patient is getting recovery from the DKA, So once the patient's acidosis level comes down, general well-being is restored. Patient is able to take his oral feeds. So in fact, like the lot of literature now say that like so the initiation of the enteral feeding at the earliest, like even within 24 hours, that will have survival benefits also. So that also one has to remember. Once this is being restored, like acidosis is getting corrected, patient's general well-being and able to take oral feeds, like we can switch over from the IV to the subcutaneous insulin. So that is also more important. Of course, somebody has raised the about the EDKA. So that is a common thing nowadays. People are taking a lot of people. They are taking SGLT2 inhibitors. They should be advised about not to do any prolonged fasting or alcohol intoxication, or even before the surgery. Sometimes people are interested to go for, sorry for my bad throat, some people are interested to go for marathons. Chennai is one place like where we get almost every fortnightly we have some marathon is going on. So these patients, while on SGLT2 inhibitor, they should be advised to keep the medication on and adequately hydrate them. So these are all some of the precipitating factor on which like they come with us with EDKA. So otherwise, it's a good presentation, a nice presentation. One of the clinical feature which I would like to say is the abdominal pain, like so because of the mesenteric ischemia. Yeah, that is also very common. Like of course, the science he has mentioned about abdominal tenderness part of it. It's a good talk by Anil. Congratulations.
Yeah. Thank you. So
Yeah.
Dr.
You want to
Sasank Prabhudesai, yeah. So Dr.
hypercolon.
Sasank Prabhudesai, your comment on this topic
Uh,
and what's your experience?
yes, Dr. Anil, very good presentation. I think you've touched upon almost all topics. But yeah, nowadays, although type 1 and DK per se is reduced, in frequency, not so much, we don't see so much. But yes, we now see more of EDK cases. So, touching point being that high index of suspicion, not many doctors still know. I mean, all the MDs, everyone, they do know about EDK, but the general practitioners, they as such are having a very low index of suspicion. Abdominal pain, as doctor pointed out, is one of the key features where you suspect abdominal pain, vomiting. These are the features. Yeah, so that's about it.
Yeah.
Everything else
Thank you,
was, I
Dr.
think,
Modi. So,
excellently
Dr.
touched.
Modi, I think one question, Dr. Panish Chandra Ranu from Ranchi was, I think already answered the which fluid is better. So,
Yeah.
what's your experience from the this that part of Bihar, Purnia? So, how
Okay,
many
okay, sir.
cases you get?
Okay,
Such
okay,
cases?
sir. I'll adjust here. First, I want to congratulate Dr. Anil Samaria for very, very nice presentation, detailed step-by-step presentation and management of diabetic ketoacidosis. It was very well explained. The most important part in the management of DKA is fluid replacement, just to combat the dehydration or hypoglycemia. And there was a controversy, which fluid is better, normal saline or ringer. Although both fluid can be given, but most of the time in our PG days and in our practice, we do use normal saline. The second thing, which is also very, very important in the management, is to assessment of potassium, because he has very nicely explained that if the potassium level is less than 3 millimole, then in that case, if we give insulin, that will further reduce the level of potassium. Extracellular become intracellular. There will be hypokalemia, and that may precipitate to so many arrhythmias, which may be life-threatening. So it is also a very, very important thing. Third thing is that we have already talked about EDK. I will just focus that. Apart from type 1, we should also think DKA in type 2 patients. When the patient is receiving a SGLT2 inhibitor, and Dr. Chandrasekhar told if someone is going for a surgery or marathon, he may be precipitated this serious complication. He may come with diabetic ketoacidosis. But one thing is very important, how to differentiate. So my take is that in every type 2 diabetic patient, if they are receiving this SGLT2 inhibitor brought in emergency department with some vague symptoms, of nausea, vomiting, or some reduction in the mentation. Because in that case, we will not see the hyperglycemic symptoms, because hyperglycemia is not a important feature, because most of the time the blood sugar is 250, less than 250, not exactly more than 200 or 300. So sugar is not high, so we won't get features of osmotic symptoms. He will not present with hyperglycemia or increased thirst. Rather, he will present features of acidosis. So we should always keep in that our mind that vague symptoms like nausea, vomiting, and reduced mentation, this possible breathing, deep inspiration, that say the high index of suspicion about euglycemic ketoacidosis. And management part is also some different. Here the fluid choice is not normal saline or ringer lactate. Here we give 10% dextrose along with insulin. So that is one. Another thing I want to share you, that a special variety of type 2 that has been explained in the newer classification of WHO, hybrid form of diabetes. There they have mentioned flatbush diabetes or ketosis prone type 2 diabetes, which presents with ketoacidosis. And most of the time, the patients are obese, and it's also present in our country, in Asia also. About 10% cases we get this flatbush type of diabetes. And here there is transient insulin deficiency that leads to ketoacidosis. When ketoacidosis part is managed, the patient remains euglycemic after insulin, and later we can manage him on oral drugs because he retains the secretory capacity of beta cells. So these are the few important things we must consider while seeing the case of DKA. And you have asked about Bihar. We see here, and most of the time, and most important cause of DKA in children's in type 1 is missing of insulin dose. And in type 2, it is an infection, or it may be a flatbush type of diabetes occurring or presenting as DKA. So
Great.
again, thank you for nice presentation by Dr. Anil Samaria. Over to you, sir, Dr. N.K. Singh, sir.
Yeah,
So
one
Dr.
thing,
Samaria,
yes,
Judge
so
Chandrasekhar,
just
any comment?
one comment. Like the
Yeah.
urine ketone is one thing like which we need to be very careful. Like so, there are in limited resource setup like we can do the urine ketone. Otherwise, it's better to do the serum ketone. So that is the most important thing because like it may misguide also, particularly in two situation. Even in normal patient with the DKA, they continue to excrete the ketones in the urine despite the recovery of the acidosis and general well-being. But the second thing is alcoholics, it may not be of much helpful. Like you said, it's better to practice the habit of culture of doing the serum ketones whenever we suspect DKA. So that is more helpful.
So Dr. Patni, so can you conclude this the first part? Then we will proceed for the desktop.
Thank you, Dr. NKC, and all the presenters and moderators. I think everything and anything was covered. And I guess everyone tried to put the maximum input. And I think Dr. Chandrasekhar has actually put out this particular point of IV fluids because this has recently been encouraged that any of these can be used. And obviously, Dr. Modi and Dr. Shashank has also given their points. So, thank you, Dr. Samaria, for excellent presentation. So, I just one query, if anyone of you can take it. Now, decay in CKD or renal dysfunction or end-stage renal disease, or the patient on dialysis, how different it is the management? Just few points, 3, 4, 5 points.
So can you repeat the question? You want
decay in end-stage renal disease or patient on dialysis. Now, these patients has to be managed in different ways. So obviously, anyone can actually give some kind of inputs on that. 4, 5
So the
important
first,
points.
so in patients with the CKD, the decay is quite rare. So that is the first thing which we need to remember. Yeah, and the second thing is like because there are two challenges which we face in patients with CKD. One is the acidosis. CKD itself can produce metabolic acidosis, so that we need to be very a little bit careful. And the second thing is with regard to the fluid management, it should be individualized, and we need to have a careful monitoring of the fluid which we are going to replace. So that is the one. And as you rightly said, like even in patients with hemodialysis, the patient can develop DKA. And if we have any correctable factor in treating these patients with DKA, it should be corrected. So that is the most important thing. And third, probably we may have a lot of the electrolyte abnormalities. Again, that could be detrimental and it determines the outcome. So in patients with this thing, like the risk factors are again same as like the patient is skipping the dose or the patient is the infections or the usual predisposing factors, and it should be individualized. I think
Exactly.
others
So I
can.
think
Thank you. I think
Prasad,
I'll just add one thing. Routine usage of potassium should be monitored. I mean, this is a very important fact which one should
Yes.
always be. That's very
very
clear that
careful in
we
the
should
potassium
understand that.
monitoring is required.
Yes. So IV fluids, as Dr. Chandrasekhar said, routine usage of potassium should not be encouraged. And obviously, more frequent monitoring and much more ICU-based kind of management is extremely important. Thank you, sir. I think we have covered practically. We don't want to go into the second talk. I think leave it
So I
to
think
Dr.
our
N.K. Singh to
today's,
take us to the next topic.
Thank you, all
right,
of
sir.
you.
So thank you, Dr. Anil Samaria. So I think we are waiting for Dr. G.V. Sattur, sir. Welcome, Dr. Himalaya Jha, also from Ranchi. So I think technical team, can you display the
Dr. Sattur is already there. Dr. Sattur is there.
Dr. Sattur is there. So can you see the PPT of Dr. Sattur? So Dr. Chandrasekhar, can you kindly introduce? Yes, I think already.
Yes, sir.
So
Yes,
can
sir.
Dr. Chandrasekhar,
Yeah, so I think it's my pleasure to invite and introduce Dr. J.P. Sattur, who is the consultant physician and cardiologist from Hubli, Karnataka. Just recently only I met him in the South Zone, Mid Zone, Capricorn, and he is going to talk on about the beyond the plot, the dynamics in the eye of coronary storm. So we are all eager to listen to Dr. J.P. Sattur, one of the most sought after erudite speaker and most popularly invited speaker in many forums. Over to Dr. G.P. Sattur.
Yeah, unmute yourself, sir. Dr. Sattur, sir, you are muted. Unmute yourself. Slides are being displayed. Yeah. Fine, sir.
I need to unmute this here. I think I'll have to.
Yeah, your voice is your voice is clear, sir.
Your voice is clear now.
Can
voice
you
is clear, sir.
unmute from your end? Can you do that?
Yeah.
That's because I'm already on a bigger screen.
You can proceed, sir. Your voice is legible and your slides are presentable.
Yeah, great. Yeah, thank you, Dr. Chandrasekhar, and very nice to see you this evening, despite your busyness. And thanks to Dr. N.K. Singh, teacher of teachers. And we all learn so much from his CME, and I am no exception. The topic that is very close to my heart is the lipids and lifestyle. And this is very much on lipids, beyond the plot, lipid dynamics in the eye of coronary storm. We all know ACS is acute coronary syndrome is India's leading killer. Every hour counts, or rather you could modify it as every minute counts. And more than 2.5 million ACS cases per year and 35% LDL related, but I think it's much more than 35% LDL. Even if it is only 35% LDL, because we don't do LDL particle size and because it is small, dense LDL, many times, maybe despite normal looking LDL, we see many patients of MI. Urgency is clinical and precision is essential. We all know it is ST segment elevation, MI, and non-ST elevation MI, and unstable angina. And although we know that these appear somewhat bit different, but they are all sort of included in the basket faced with the patient. More or less, apart from certain interventions, the remaining management in hospital also remains the same. The guiding principle, LDL, is the primary target. Many studies have shown LDL has got to be the primary target. I always wondered why not VLDL, why not triglyceride, why not LP little a. But somehow, very many studies, both animal models and human models have shown LDL is the sort of leading primary agent, primary target rather. Lower, sooner, longer, and very lowest is the best. Why it should be lower? Target less than 55 is a class 1 recommendation. Consider less than 40, of course, in patients with recurrent events. Sooner, initiate high intensity statins as soon as possible without waiting for the lipid reports. I think this has to be underlined and it is in capitals. Very lowest is the best. Landmark trials, we all know the Fourier, the Odyssey trial, have shown that very low LDL is safe and provides incremental benefit. We all know the traditional management. We use statins to reduce LDL-C levels, but emerging evidence suggests ezetimibe, PCSK9 inhibitors can definitely give rise to the additional profound LDL reduction. And this has to be sort of seen to in every hospital setting where a patient comes in with ACS. This is all well known. Immediate therapy, you admit the patient, he'll be put on oxygen. I'll not go into all the details. High intensity statin, regardless of their initial cholesterol levels. Just lowering cholesterol, we know it takes at least 2 weeks for cholesterol to come down when you give statins. So then how does this statin work then in an acute setting? It is because of the pleiotropic effects. It looks to me that the word pleiotropic probably came from initiation of statins more than 2 decades ago. My other co-panelist, Chandrasekhar, Dr. Singh can sort of join their voice in this. The pleiotropic effects include anti-inflammatory action, plaque stabilization, and improved endothelial function. And I already said, without waiting for the lipid profile results, think of using statins, atova in 80 milligram once a day, and rosuvastatin 20 to 40 milligrams. Well, there have been certain good Indian studies across over 20,000 patients in CREATE registry. Average LDL was 99. This is very important to realize. Most of the patients that enter the hospital with ACS have near normal or even normal, not very much raised LDL. Once they go into high like 190, you think of familial hypercholesterolemia. So in other words, we do get a normal LDL in large number of patients. And why is it so? Because this LDL, whatever we have, call it genotype, call it phenotype, this LDL is small, dense, and highly atherogenic molecule. And of course, triglycerides has to be around 130. With a high carbohydrate diet, no need to say we have definitely higher triglyceride. The Kerala ACS registry and InterHeart study, around 40 to 50% of ACS patients have low HDL, 35% have high triglyceride. And the ICMR India study, 80% of people with heart disease have at least one abnormality in their blood, in their body, half a low HDL. In fact, Yusuf in the InterHeart study also mentioned no MI can occur without at least one risk factor. The acute phase paradox, this is important. The counterintuitive observation that the biomarkers associated with increased CV risk, like LDL, lipoprotein A, lipoprotein little a, can actually decrease significantly during the acute phase or the ACS. This temporary drop leads to an underestimation of the patient's baseline levels. LDL, according to one literature, drops by a whopping 30% following an MI, following an ACS, and HDL may be lower than usual in the first few days. So early measurements tend to be more accurate. Lipoprotein little a is an independent, genetically determined risk factor. Growing evidence supports its role in both the onset and the recurrence of ACS. And the Indian data, we all know we have very low HDL cholesterol, correspondingly high triglycerides. And although more than around 840 milligram triglyceride is supposed to account for pancreatitis, uh, I haven't seen many pancreatitis patients with even very high triglycerides of around 1,000. I would like the view of moderators also. Now, only mild to moderate rise in LDL. So this is all the CREATE, Kerala, ACS, all combined together. Different between the Indian patient and the Western patient. LDL, as I said, normal level of around 100, whereas you could get a bit more LDL in the Western population. By Western, we mean predominantly American or some European population. And HDL, of course, is around 35 to 40. Triglycerides are definitely almost in the same range. Now, what does this mean for treatment? Don't just focus on LDL. Focus on raising the HDL, not when patient is with one ACS, but recurrent events are very common in us. That's the reason why, apart from LDL, these issues are very important. Healthy fats, low exercise, lowering the triglycerides, and statins, of course, are a mainstay. Pathophysiological role of lipids, atherogenesis, lipid accumulation, we all know under the endothelium and the oxidized LDL is highly heterogenic, leading to chronic inflammation and, of course, the foam cell formation. Plaque instability, fibrin layer out are more prone to CS. Inflammation and lipids, we already heard about the oxidized LDL. Acute management strategies as dual antiplatelet therapy, invasive versus ischemic, all whatever interventions are done, we don't need to go about it. What about the medication pathways? This also we all know in hospital, it is different setting. Patient can go in for a primary PCI, and of course, one has to address other drugs which go in the line by line. Now, so long for statins to reduce LDL? This is a very important point because it takes at least around 1 to 2 weeks and max effect occurs in 4 to 6 weeks. So for the lipid panel to be right, for LDL to come down when a patient is in ACS, and what is the use of high intensity statin, that is where the pleiotropic effects come to action. They stabilize the plaque, anti-inflammatory effects, improve endothelial function. We know that decreases the generation of reactive oxygen species, or the ROS, of course, immunomodulation. Now, defining the limits of statin benefit. This is very important because statins are not beneficial universally for every high-risk patient, including their presentation at the time of ACS. Maybe some patients with on dialysis or advanced heart failure may not be the right candidates. Now, $1 million question: atorvastatin versus rosuvastatin, which is a better molecule. Atova, we know we use in the dosage of 80 milligrams, but once the Rosua has come into play in India, and most of the companies are now selling it at a relatively good price. So using rosuvastatin by cardiologists and physicians has become very common in the acute setting. And both of them, Atorva and Rosua, reduce LDL almost the similar extent. Extensive trials on Atorva, but a bit fewer in Rosua. So question is, which one is more potent? Quite a few studies have been done. It's too long to quote all that. One study from Japan said both Atova and Rozua have almost equal outcomes. Choose what you like, choose what is available. So I thought Atova or Rosuvastatin, let us compare it to the car. New 2025 Mercedes-Benz S-Class, dependable, a masterpiece of luxury, elegance, that is your atorvastatin. Rosuvastatin, Tesla Model S, sleek, futuristic electric car. No matter which car you pick, Mercedes or Tesla, the destination is the same, a healthier heart after ACS. So who wins in all this? The patient wins if we treat ACS properly. And of course, we know the Fourier trial and also know the Odyssey outcomes. The Fourier used the evolocumab and the Odyssey used alirocumab. And of course, they were all into major MACE. We all know the results were extremely favorable. Both Fourier using evolocumab and Odyssey outcomes, alirocumab, were landmark studies. And you can go even to unprecedented low levels to around 30 milligrams. I heard one of the lectures where some patients of certain cardiologists, the LDL is a less than 10 in single figures. And I'm not sure whether taking low down, although there aren't any sort of dementia or worsening Alzheimer's by that, but I'm not sure. And I wouldn't really risk using a pretty high level in high risk patients. Ezetimibe, of course, lowers LDL by inhibiting the absorption of the intestine. It is used as an adjunct to statins if you want to enhance the effect in ACS patients. Clinical evidence, improve it trial. When to use, particularly considered in ACS patients who do not reach the LDL targets on high intensity statin monotherapy or those who are intolerant to the high intensity. And of course, this particular ezetimibe molecule has major cardiological guidelines all over the world, including the Canadian guidelines, have started using this. And of course, our own Lipid Association of India, the Indian study, acute coronary syndrome. It's quite a busy slide. I'll just sort of cut it down. You may have a statin naive patient. Patient may have a low to moderate risk. Patient may be on a high intensity statin. Patient may have established statin intolerance. So if one wants to see, one thing is on admission, if they're already on HIS, continue them. And also if need be, ezetimibe. And the target LDL should be less than 50 or for Indian patients, less than 30, although European guidelines touch the lower end of around 44 milligrams. But in India, according to LAI, which probably is very true because of genotypically, phenotypically, we are highly prone to ACS. And of course, LDL goal target, if you have achieved with the high intensity statin, continue. And if it is not, then think of adding some other drugs. Despite optimal LDL lowering, residual risk persists, particularly from elevated triglyceride, Lp(a), and some sort of inflammation. And we now know inclisiran is now available in India for LDL-C lowering. Trials are ongoing for Lp(a) lowering agents. After the patient is discharged with ACS, follow-up is very crucial. Check a follow-up panel of repeat panel around 4 to 6 weeks. Evaluate LDL goal, follow the international guidelines, and I already said Lipid Association of LAI Indian guidelines. LDL targets for patients with ACS with a very high risk, keep it less than 55. Secondary goal is to achieve at least 50% reduction of the baseline LDL level. Future direction and research gaps, emerging technologies and approaches, proteomics and metabolomics, beyond traditional lipids. It could be FOB. I'm sure in 1 decade, we are probably going to do FOB and LPA in every sort of laboratory. We in Satur Medical Care and Heart Care, we do LPA and ApoB regularly. Probably even every physician in two-tier towns, including, we have to start ApoB sometime because that is the basic moiety in all atherogenic molecules. And of course, NMR-based protein profiling, RNA therapeutics beyond current targets, next generation ASOs or siRNAs. Gene editing approach, very much. The CRISPR based therapies for monogenic disorders is on, and one time treatment with potential lifelong not to have an ischemic heart disease. It's a very tall order. But I think probably once we start touching the genes, we could probably achieve this. Take home points, not just LDL in Indians. Lipid abnormalities directly contribute to heart attack. In India, the problem is often low HDL and high TG, sometimes only with modest LDL elevation, as I discussed before. Indian patients develop ACS at a younger age, and most of them have multi-vessel, unlike the Western population. And lipid management in these people is very vital. And of course, awareness is important. This is the last slide. On the left is BKS Iyengar, practiced yoga all his life, died at the age of 96. Kushwant Singh, a great orator, a great writer, drank whiskey all his life and died at the age of 99, survived 3 years, more than BKS Iyengar. Moral of the story? Whiskey gives you a 3 year edge over the yoga. But that doesn't mean just don't depend on our genes for ACS. Lifestyle plus statins in high risk group is the road to go. Thank you very much.
Great lecture, sir, again. And in very short time, you have given a very, very important message to us. So I think let us have some starting comment by Dr. Chandrasekhar, and then we have got few questions also. Yeah.
Yes, it's a nice talk by, as usual. He usually comes and he mesmerizes everyone with his style of talk. I usually admire his talk. So the dyslipidemia is becoming a very common issue. So the alarming thing, we know the ICMR in-depth study, where it is projected that millions of people, the obesity is among 340 millions, almost close to 200 million people are having. The dyslipidemia part of it. The most alarming thing is even people the adolescent and the childhood and the early adult they do have this dyslipidemia because of various factors which all of us know: the physical inactivity, the lifestyle they indulge, the food they take, all these things, sleep, all these things. It influences. So the thing is there are many guidelines. Many times we do see patients with the dyslipidemia, but we wasted to reinforce the lifestyle things or initiate any therapeutic measures. So that is the thing. So the lifestyle measures are the most important thing. The food they take, the it should be avoid a trans fat, saturated fat, and energy dense food, and the kind of physical activity which they should do. All these things should be taught and educated from the adolescent age group also. So coming to the another the component which we commonly see in patients with the dyslipidemia is the subset people with the metabolic syndrome or with the diabetes. So diabetes is we know that it can increase the small dense LDL and the triglyceride and decrease in HDL. But remember that it also can increase the VLDL and increase in the ApoB and ApoB3, as already alluded by Dr. Sattar, and increase in the LPA. So this is a very important thing, and many times, when the patient is despite, so we there is another practical thing which we come across is the initial, statin inertia. So the even before they come to a visit to our clinic office, they read all about statin, and they usually it's they say a statin has got a lot of side effects, including muscle symptom and so on. Even new onset diabetes also, sometimes the patient usually they come and discuss with me. So the thing is it takes some time for us to educate all these patients about this, the importance of insulin, the benefits definitely it outweighs the risk. But the thing is, like the people, my concern is, like sir has already said, like how the dynamics of this lipid core, how it's going to affect the plug, and once the patient develops a ACS, like we need to put the patient on a high intensity statin, say for example 80 milligram. We need to wait for 4 weeks for the LDL target to be reached, like less than 55. Then after that, like we need to put the patient on either a pemvidinic acid or ezetimibe, or if necessary, PCSK inhibitor also. So, but my concern is like the people are in the active age group, that is between the 20 to 39 age group. So that's where like most of the people, they have cluster of pre-diabetes, pre-hypertension, and maybe the metabolic syndrome, all those kind of things. Like we need to, all these patients should undergo ACVD risk scoring, and we need to do the risk scoring. Many times people think that like only patients with the diabetes they require statin. Not so. Like so, we need to do the risk scoring, and if the risk score is between 5 to 7.5, we have to take a shared decision making with the patient to start the patient on statin. And if the risk score is more than 10, like we should initiate on a statin. So that is one thing. So second thing is all patients with, as per there is a nice guideline by the SEC AHA guidelines, like 2017. Still, it's a very good guideline. Like it says that all patients with diabetic, they should be initiated on moderate to high intensity statin. So that is like not the 5 milligram of atorvastatin or 10 milligram of atorvastatin kind of thing. They should be initiated with the moderate to high intensity statin. I think it's a good talk by Dr. Satur, and I may try
Yeah,
to
yeah.
contribute a little bit when the question comes. Like there may be, I'm sure, a lot of questions with regard to the moderate high intensity, the SAMA, the statin associated muscle symptoms, all these things. Like we can talk a little later, like when it comes. Okay. Over to
Yeah,
Dr.
here
NK
I
Singh.
say,
Yeah.
thank you, Dr. Chandrasekhar. So here is a question by Dr. Sudhir Jha from Sitamarhi. A lady patient, 64 years, with hypothyroidism, obesity, LDL 270. She is intolerant to statins. So ezetimibe and bempedoic acid, what should be the preferred line of management? Satur, sir?
Yeah, sir. Now, if this patient hasn't had any ACS and her physician has found out all these findings and LDL almost in the range of FH, at that around 190 milligram LDL, she is sitting on a hotbed and very likely on the path to ACS. She definitely needs a higher dose of statins, as we thought about Atorva and Rosva. I would rather prefer and start, say, Rosva statin in this lady around 20 milligrams per day and watch for any symptoms. And secondly, lifestyle. I remember Dr. Singh telling in one of the talks on the platform, physical talks, he said for Indians, it is not 150 minutes of walking 5 to 7 days a week. It is 300 minutes of walking because we are highly insulin resistant species. So I think these are all the
Sir,
things
just I will
that,
interrupt you, sir. Here the question is, patient is intolerant to statin.
yeah. Okay. Now, coming back to intolerance, there are only three issues. One, stop the present statin that she is taking. Second step, go to another statin, one of the two. She was taking atorvastatin, you say?
Yeah, so no, she has not mentioned, but
No, has
only
she
here she
said,
has,
is
yeah.
there any both atorva or rosva? I mean, what is she? Only
A
statin.
lady patient only intolerant to statin. They have not mentioned which
Okay.
statin.
Now, this intolerance to statin is a very funny term because the doctor has to reassess by giving an overdose. For example, people who don't tolerate 10 milligram atorva can end up tolerating 5 milligrams of rosuvastatin. So this is very important. And secondly, I very well want to quote one of the Australian speakers whom I just heard his lecture some time ago. He used to say symptoms like muscle pains that you get on a high dose of statins. Yes, it is taken. But if the muscle enzymes or there is no evidence of any renal involvement. He said a beautiful word, I want to quote it. Muscle, you ask the patient, would you prefer a muscle pain or would you prefer an anginal pain? So I think, this answers much of that doctor's question. One can think of using ezetimibe, if that patient doesn't want to use
Yeah.
statins.
Thank
And
you.
Sir, I
Thank you very
just
much.
wanted to
PCSK9 is
add.
Yeah, Chandrasekhar.
Yeah, so if the as sir has already said, like if the LDL is more than 180, I would like to strongly think in terms of a familial hyperlipidemia. So that is one thing. In that case, like I would like to, most of the statins also may not be working for those patients. We may have to resort to statin if the patient is still persisting statin with the non-statin therapies also, pemvidutide, or if we need to motivate the patient to take the PCSK inhibitor. That is the best thing because considering a rather clustering of things. As Sir has said, like the statin intolerance is a vague term. Like, so what do they give actually? So that's not been given in the thing. Like maybe the patient gets some kind of unwell after taking the side dose of statin or muscle symptoms. Like when a elderly lady, like I would like to rule out, in case if the patient wants to take a statin, like I would like to rule out evaluate for the hypothyroidism and vitamin D deficiency also. So that can also commonly contribute to all these
Yeah,
things. So
yeah,
Yes,
yes,
good
sir.
Dr.
point.
Chandrasekhar, patient is already hypothyroidism. Yeah, I think, but they
Yeah,
have not. Yeah,
yes. So then that has to be corrected. Like so,
yeah.
yes, sir.
Hypothyroidism
One, yes,
And
sir,
self-limiting.
avoid
Dr.
dehydration.
Yeah. So I think next question is by Dr. Abhay Singh Deora from Jodhpur. If the patient is already on triple drug, therapy of statin, utomitinib, and bompetic acid, the time of developing SES, what should be the strategy in such cases? Already on
What should
triple
be the?
drugs, already on
Uh,
triple drugs, but
yeah, what
PCA,
should be?
but patient has developing SES.
What is that? I'm not able to understand the last part of the.
Yeah, Dr. Bijay Patni, can you read that?
Is there in the chat?
Yeah, Abhay Singh, yeah, go in the chat.
Yeah, I'm just having a look at.
Okay,
So can I
sir.
add? Can
Yeah.
I?
So you can see Dr. Chandrasekhar
The
in
question
chat
is
box.
if the patient is already on the triple drug therapy of statin, ezetimibe, and bempedoic acid, at the time of developing of ACS, what should be the strategy in such cases?
Okay, that's a very good question. This is already shown in the LAI slide. We did show in LAI slide. If the patient is already on these triple drugs, question is she or is he taking high intensity statin? So it is extremely important that 40 milligram rosuvastatin be added if the patient goes into ACS. It's good, maybe because of atorvastatin or 10-20 she may be taking, probably helped her in postponing her ACS. But nevertheless, despite using triple drugs, it has to be, in what proportion is she using, how long is she using. I think that's all very important.
Yeah, sir. So
And
in
we
the
now
relation
know
of first,
PCSK.
yeah. So, sir,
Yeah,
in
we now
relation to
know
the first
PCS.
question,
Yeah.
sir. Yeah, in the first question, now Sudhir Chand Jha has told that he has tried all statins many a times and intolerant to all statins. That was intolerant to all statins. In that first question.
I think can I come in, please?
Yes,
Yeah.
sir.
You can anytime you can.
Yeah, I think this is not a very uncommon scenario, sir, that the patient is absolutely intolerant in spite of whatever you said. He could be an hypothyroid or vitamin D deficiency, all ruled out. Patient can still be intolerant to statin. And let me tell you, we have seen cases, even on 5 milligrams to 10 milligrams, the patient become intolerant to the extent, once he stops it, he is fine. It's not psychological analysis have been done. It does happen in certain cases. But what is important is that regarding this particular patient who has been intolerant to all the statin, if that is an issue of only lowering of the cholesterol without obviously the patient being ACS or etc., then bempedoic acid with ezetimibe combination does work well. I've seen a few cases if they cannot actually have the option of PCSK9. And I think we can give this particular combination as to lower the LDL cholesterol.
So we need to check the LDL. Like, what is the LDL level? Like, if the patient assumed to develop a
Yeah,
ACS,
definitely,
like we need to
definitely,
know the LDL
definitely.
level. So that is more important.
Absolutely.
Like so accordingly,
LDL
like
was
we can decide the therapeutic choice.
I
LDL
think
was
one question
270
sent to
as per.
me.
So,
Yeah. Dr. Patni is quite interested in LPA. So one question has come.
yeah.
Sir, what is the
So
relation with the LPA and the statin? Whether the statin is effective for lowering the LPA, lipoprotein A?
That's a very good question. There is no drug yet that can reduce LP little a. Inclisiran is something that is said to be very hopeful molecule, but that has again got to be used with statins. Whether statins reduce LP or not, it just can't use the other drug, inclisiran, very much available in India. But in the setting of ACS, I don't think that is useful. I would like others' views because it takes some time to act. Even the statins, it is not their lowering cholesterol, as we saw in my slide. It is a pleiotropic effects that protects the patient from further damage.
So
Dr.
LP small,
Yeah.
sir,
yeah, LP small a is a very, the newer thing, like a lipid parameter, like variable, which we need to be very cognizant of that. Like, because despite statin, the patient can develop a ACS. Despite statin, the patient can develop a sudden cardiac death. Like, are we missing anything? The missing link is many times like we ignore the triglyceride part of it. The second one is the LPA part of it. Of course, the LEA also has given some clear guidelines, like the recent guidelines. It has given that like all patients with dyslipidemia at least once a year, like they should check their LPA level. If the level is more than 30, like we should evaluate them for ASCVD risk. So that is the most important thing, like which we need to do. Of course, more than 50, definitely we need to treat such patient, because I think all of us, we all know that so the Interheart study by the Inas and Inas, so he's the one first gentleman to show that a LPA would play a very major role, particularly in the South Asians. So in fact he did it in NRIs in US, but the thing is the patients with increased LPA, as Sir has already said, the statins may not be of much helpful, only the PCSK or a LPA apheresis. So that is the treatment of choice for patients with elevated LPA.
Dr. Sasank, your comment on this
I,
talk and
can
diabetes.
I say a
Yeah,
few
yeah,
words about this particular?
definitely.
Let's look at the Abhay Deora's question that even at the time of developing ACS, the patient was on statin, ezetimibe, bempedoic acid. Probably the patient did not check his LPA. This could be the reason. Here, I am telling about a live case, I think discussed in 2020 on 22, if Dr. Modi and Dr. NK Singh do remember, on a CCDSI forum, I spoke about an LPA case. And that was a case, a live case, which was with me, and he happens to be a physician himself. He's a pathologist rather, who had a ACS, who underwent angioplasty, went back to US, and the very next day he went to Goa, near your place only, sir, Dr. Sattu, sir. So he
Okay.
went to Goa and he came back to Calcutta and he developed again an ACS. We took him in and we did angioplasty again. Okay. So what we were wondering, what is going wrong? This patient was on maximum statin and he was on a dual antiplatelet because it was within 1 year of the angioplasty.
Yes, yes.
So there, what we saw was the LPA was more than 300. The LPA was more than 300. That time we didn't had anything at hand excepting, if you remember, nicotinic acid, right? That was, this niacin. That was the only treatment which we had.
Correct.
So, we were left with no option. We initially thought aspirin resistant and all those stuff, etc. And I think we gave him 1 gram of this, and later, because it was basically almost ruled out that we did not give this particular stuff anymore in LPA lowering and all, but it helped. The patient never had a ACS for now 20 years, let me tell you. And the LPA came down to less than 50. From 300, it came down to 50. So basically, LPA is an important component. I have done a study, the first study in India, let me tell you, way back in Beer Singh Hospital, 1997, on our population on LPA. And you will be surprised to know the extent of LPA more than 30 was noted in more than 37% of the population in Southeast Asia, in our population, Calcutta. So it definitely has an important impact. And probably, as Dr. Chandrasekhar said, this has become an important, I think, consideration now. Even every lie has also given its own recommendation to check LPA once in lifetime at least. And with the antisense oligonucleotides coming in now, probably we have some kind of leverage as far as the management of LPA is concerned. I mean, this is my take. Obviously, you can add up to it, please.
Yeah, so I think now respond at RK Modi. So I think we are talking much and much about the lipids one in real scenario. How many cases you get in practice which lipid levels are now the lipid association saying that LDL should be less than 50, less than 50, 40, 30. So is it possible to get in the real world scenario? Dr. Modi and Dr. Sasank both.
Yeah, in fact, it is not very easy to attain a desirable level. But we see, we definitely target LDL, but we also see non-HDL cholesterol. That is the secondary target. So first we target LDL, we want to keep it down, and if it is not possible, or if we use one or two drugs, then we also see the secondary target, that is non-HDL cholesterol. Clearly that.
So, yeah, Sasank, Dr.
Uh,
Sasank, your take on?
yeah. See, it is very possible to achieve these levels. In fact, today I just had a elderly lady with LDLC levels of 34, and unfortunately, she's presented with stroke-like symptom. But one thing I would like to point and we should not miss is probably look for homocysteine levels as well. That also could be, and we're going and looking for like LPA, LDL, but also homocysteine is one of the possible causes. So yes, we can achieve that level, but we have to look for other causes as well.
Yeah, that's true. That's a really good message that we can achieve, but we should have a constant evaluation of the case. So, Dr. Sattur sir, what is the residual risk reduction? How you do in your practice? Residual risk, because
Residual.
even in many cases of the MI or ACS, we find that the cholesterol levels, the lipid profile is normal. But they are getting this MI or ACS. So how? I think there is still a website saying the residual risk reduction. So what are the question? Why it occurs and how to deal with?
Residual, when we talk of residual risk reduction, it's like opening Pandora's box. Because I would, in such people, PCSK9 is something that one can really think of using multiple drug usage. Maybe statins, maybe plus PCSK9, maybe plus bempedoic acid, maybe plus ezetimibe. Just mixture of all these drugs in case the patient has come with ACS. In the absence of ACH, if the FH is proved, I think I would definitely assess the coronary tree and depending on that, assess the follow-up. They are naturally heterozygous because homozygous won't put on that long.
Yeah, thank you, sir. So we have 2 minutes left. So I think I will take home messages from our first message. Sattur sir, your take
Can I
home
just
message.
make one comment, Dr. Singh?
Yes, sir,
One
your
second.
take home message, sir. Yes, sir. Last your take
One
home
second.
message.
Yeah. I just started statin. I mean, we don't have any history of MI in our family. Everybody lived 90 plus. Hopefully, I should live some years longer. But I thought, having known the lipids so deep, I should start on atorvastatin or Rosuva. Atorva 10 did not suit me. 5 did not suit me. Half tablet of 5 did not suit me. I switched on to pitavastatin, 4 milligram. That has worked wonderfully. So I think that again is an important take home point. Just don't write them off that they are intolerant to statin. Pitavastatin is something one should try.
So
I
pitavastatin
think
is a weak statin, but in patients with muscle symptom like pitavastatins are the treatment of choice, sir. It's a
so.
weak
Yeah, Dr.
statin.
Chandrasekhar, now you can start with your take home message for both the talks.
Yeah, yes, the diabetic ketoacidosis is a preventable cause of mortality, so that we should prevent the decay from occurring as someone is getting decay, and it's one of the treatable emergency, and we should not let patients die of decay. Of course, the fluid therapy is the core, the principle behind the treatment of decay. Of course, with the regard to the dyslipidemia, we do have the missing link. Now we have some evidence to say that like LPA is the culprit for the malignant or premature atherosclerotic cardiovascular death in patients, particularly in the young and middle age, or in malignant forms of atherosclerotic cardiovascular disease. LPA is the thing. At least all of us, I think I appeal all the doctors should do at least LPA once in a year.
Yeah, so Dr. Sasank, your take-home message. Unmute yourself, unmute. Unmute yourself. Yeah. No, it is, yeah,
Yes,
no.
sorry.
Yeah.
Am I audible? Yeah.
Your take-home message.
Yes, sir.
Excellent
You are.
talks. Excellent talks. I don't think I can add anything else further to this. Just a conclusion, I would like to say that I'm extremely proud to moderate Dr. Satur, who is a colleague of my mother, Dr. Shashikala.
Yeah.
Okay, great.
Yeah, I was about to ask you that. Yeah.
So, Dr. R.K. Modi, your take-home message.
Yes, sir. Yes, sir. My take-home message regarding ketoacidosis that it is really a treatable and preventable emergency, and we should also increase. We give education to our diabetic patient. That is one. And for this dyslipidemia, obesity, and this all non-communicable disease, I have a different view. That in spite of talking only about the secondary prevention, should not we talk about its primary or primordial prevention? Oh, I just sharing that genes when we talk about these things, genes are not modifiable. But if we look to the epigenetic factors, they can be modified. And there are so many factors which give epigenetics and some protection regarding this whole non-communicable disease. And if we employ all these factors to youngsters, to school-going children, probably we are doing something good for the society. And we should also talk about this primary or primordial prevention in the CME India. So, sir, thank you very much.
Thank you. So, Dr. Vijay Patni, now can you propose a vote of thanks with your message?
Yeah, thank you. I think it was an excellent session. Both the talks were very well deliberated and interacted as well by our moderators and the whole team today. Special thank you, Dr. Satur and Dr. Samaria sir, for giving their talks and giving us insight into the various aspects of decay and the living management. And Dr. Chandrasekhar sir, Dr. Sushant, and obviously to adding to a lot of inputs from your side, particularly Dr. Chandrasekhar. I think a lot of points which you have raised was excellent and it was of importance actually. So, and Dr. N.K. Singh, sir, as always, doing an excellent job of taking this particular forum to an excellent height and bringing every time a new topic and the excellent masters of the trade to the code, I would say, to the forum. So thank you for that. And thank you, the team, Pratik and others, the tech support who has given this support for long now. I think we are doing every month once the CME in India and USB webinar. And it has been of great success. So thank you all once again. And I'll request the team. Dr. N.K. Singh, would you like to add something?
Yeah. So I think thank you, Dr. Vijay Patni. You great help always. And Dr. Modi, Dr. Sutur sir, Dr. Chandrasekhar, Dr. Samaria, and Dr. Sasank. I think this was a great session. I think many people will watch later on the YouTube. So now I will just say good night to you all. Vaishnavi from USB, are you there? Because this platform is hosted by the USB. Thanks the team.
Yes, sir, I'm there.
Yeah, can you end the session?
Yes, sir, sure. Thank you so
Yes, sir.
much.
Yeah, so I think
Thank you,
I
sir.
think
Thank you
now
for
good
having
night to
us.
you all. So thank you again. We will meet next
Thank
month
you.
again.
Good night.
Thank you very much.
Thank
Good
you.
night.
Good night.
Good night.
Good
Good night.
night.
Thank
Thank you.
you.
Good night.